So for introduction, most viral infections are self-limiting, mild, and confined to the upper respiratory tract. And upper respiratory tract infection may spread downwards and cause more severe infection and even death, such as in cases like influenza, respiratory syncytial virus, and COVID-19. It can become severe and can even cause death. So for the mode of transmission, there is direct transmission and indirect transmission. And for the direct transmission, it depends on the size of the droplets. Well, if it's a large size, more than 0.5 micron, the distance can go is only about 1 meter only because of its large size. It's heavy, so that's why we say social distancing 1 meter at least. And for aerosol, this is when the healthcare worker, they do healthcare procedures in the ICU, and they do certain procedures which produce aerosol. So this virus can spread during the procedure. And then another one is airborne. Airborne means even if the patient is in a different room, but the virus can still spread through ventilation, aircon ventilation, exhaust pipes. So even far away, still can be spread when the mode of transmission is airborne. So certain virus, they spread through droplets, certain both droplets and aerosol, and certain only airborne. And another mode of transmission is indirect. Indirect is when the person's hands hold something, a surface, an object, and then the virus stay there on that surface. And then somebody come along unsuspectingly a few later, maybe a day later, and touch that surface, and that person get infected. So this is called indirect transmission. So for epidemiology, certain viruses, they are prone to infect certain ages, like RSV, adenovirus, and parainfluenza virus. They are more towards children. Children are the ones who usually get infected. So rarely do adults get infected by RSV, adenovirus, or parainfluenza virus. Mostly are children. And for RSV, bronchiolitis is the leading cause of hospital admission for infants less than 1 year of age. So when the infant less than 1 year come to you and complain and presents with symptoms like asthma, but it's less than 1 year. So most probably it is bronchiolitis, not yet asthma. You cannot diagnose asthma yet. Most probably bronchiolitis. And the most common cause of bronchiolitis in the infant is RSV virus. However, their infection confers only limited protection and immunity. So even if you have been infected before, there is a chance that you can still get the infection again. Because the immunity you get from the first infection is only a limited protective immunity. It's not enough to prevent the second infection, and thus patients can become infected and ill repeatedly throughout their lives. So influenza virus can occur in any age group. The most common cause of viral pneumonia in adults and most susceptible to infection are children less than 24 months of age, old people, immunosuppressed people on chemotherapy, diabetic patients in ICU, leukemia patients. All these immunosuppressed patients, they are more susceptible. People with chronic medical conditions like diabetes, heart, or lung disease. So these people are more prone to the infection. And some viruses, they have seasonal variation. Like countries with clear 4 seasons, then influenza virus, they are more, the graph, you will see the epidemiological graph, it peaks during late winter and early spring, December to April. And peak activity in a community usually lasts for 6 to 8 weeks. But like in our country, it rains all year round. So we don't have this seasonal. You can get influenza throughout the year in Malaysia. In the equator, we have rain all year round. But countries with 4 seasons, usually December to April. And then there is RSV, December to March, para-influenza. One occurs in the fall of odd-numbered years, two in autumn, and three in late spring and early summer. And adenovirus year-round also, more in late winter, spring, and early summer. So for clinical features, the clinical features, some virus they tend to infect the upper respiratory, and this causes features like common cold, rhinitis, you have runny nose, and tonsillitis, pharyngitis, you have sore throat, and sinusitis, and otitis media in the middle ear, and sinusitis in the sinus, in your skull, you have a air cavity sinus, can get infected. You can get headache, runny nose, and you also can get croup, acute laryngotracheal bronchitis, also known as croup, where you have stridor sound during inspiration. And then there are also certain virus, they cause lower respiratory tract infections. So the cutoff is your voice box here. So color in red is the lower respiratory tract, in blue is the upper respiratory tract. So the larynx is the cutoff. Below the larynx is lower, above the larynx is upper. Okay, sorry. So for the virus, rhinovirus causes the common cold, and the attachment mechanism is the capsid protein, which binds to the ICAM type 1 molecule on the host cell. The coronavirus causes the common cold, SARS, MERS-CoV, and also the COVID-19. And the attachment mechanism is the virus spike protein, which binds to the host ACE2 receptor. Adenovirus causes mainly pharyngitis, also conjunctivitis, and bronchitis, because there are a lot of subtypes of adenovirus also. So different subtypes, they cause different clinical pictures. And then the mode of attachment is the knob domain of the fiber protein binds to the host cell receptor. The para-influenza virus may also invade the larynx, causing laryngitis, and the attachment is the viral envelope binds to the glycoside on the host cell. Respiratory syncytial virus may also invade the lower respiratory tract, causing the pneumonia, and it attaches through the G protein of the virus, which attaches to the glycoside on the cell. And influenza virus may also invade the lower respiratory tract, causing viral pneumonia, and the viral hematinic acid protein binds to the salicylic acid receptors on the host cell. So the salicylic acid is present in the lower respiratory tract. So this why it can cause the lower respiratory tract infection. And for the COVID-19 coronavirus, it attaches to the ACE2 receptor. So this ACE2 receptor is not only present in the respiratory tract, but also in the kidneys and elsewhere in the heart. So that's why it can also cause myocarditis. It can also cause kidney failure, multiple organ disease you see in COVID-19, which can also cause you see not only the lung symptoms, but also all the severe symptoms you see in COVID-19, because of the COVID-19 attaches to the ACE2 receptor on the other organs as well. So we go one by one. Common cold. Common cold is actually inflammation of the nose and throat, characterized by watery nasal discharge and sneezing, runny nose. So this is a mild disease, common cold. Everyone has experienced this disease before. Symptoms: watery, sneezing, mild sore throat, fever is not common, and rhinovirus and coronavirus are the major causes. So common cold is not one virus. It are a lot of viruses which can cause common cold. That's why we cannot produce vaccine for common cold, because a lot of virus. You don't produce vaccine for vaccine. You need to target very specific. Common cold is a lot of virus. You cannot target so many viruses. And duration is only 1 to 3 days. You recover by yourself, resolve spontaneously without any treatment. Your immunity is enough to fight the common cold viruses. So lab diagnosis, you don't need to send sample to the lab. You can diagnose clinically. Treatment, there is no specific antiviral treatment. Symptomatic, usually Panadol is enough. And prognosis is self-limiting and recovery is complete. Okay, next we go to pharyngitis. Pharyngitis is acute inflammation of the pharynx, characterized by sore throat, pain on swallowing. The pharyngeal mucous membrane may be mildly infected or severely inflamed and may be covered by exudates. About 70% of acute sore throats are caused by viruses. So again, a lot of viruses, not just one virus. Adenovirus is the most common, but other viruses as well, like coronavirus, parasite influenza virus, and RSV also can cause pharyngitis. Diagnosis, you don't need to send sample to the lab. Just clinical diagnosis is enough. No specific antiviral treatment. Antipyretics may be used. You can give Panadol. And for viral pharyngitis, you don't give antibiotics, because virus you cannot treat with antibiotics. Antibiotics is for bacterial pharyngitis. So you need clinically you need to differentiate whether it's bacterial pharyngitis or viral pharyngitis. So this is a problem in GPs. They over prescribe antibiotics. So when you overprescribe antibiotics, you can lead to antimicrobial resistance. So antibiotics become ineffective anymore. So you need to be careful with the use of antibiotics so that the normal flora can be protected, and so that they can remain susceptible to, when they really need the antibiotics, you can really give the antibiotics. Not during viral you don't give. Then next is croup. Croup is acute laryngotracheobronchitis. There is inflammation of the larynx, inflammation of the trachea and the bronchus. So usually occur in infants and young children, characterized by swelling in the airway lining, so that the airway narrows and breathing becomes difficult. Because it's extrathoracic narrowing of the airway, it causes stridor. If it's intrathoracic, below the trachea, below the larynx, you cause wheezing. So that's the difference. Wheezing is expiratory. Stridor is inspiratory. Is extrathoracic. Wheezing is intrathoracic. I hope you can differentiate that. So the viral etiology, also many viruses like para-influenza virus type 1 and 2, infants and young children, RSV, and influenza viruses. So you should listen, maybe you see YouTube or somewhere, to differentiate between stridor and wheezing. This is a good clinical skill you need to acquire. So clinical features are usually preceded by cold symptoms before they get the croup, and then they have fever, rapid and shallow breathing, barking, spasmodic cough. This is what I said just now. You need to hear to appreciate this sound: barking, spasmodic cough, inspiratory stridor, steady stress, and hypoxia and cyanosis. This is the narrowing of the airway. Okay, lab diagnosis. Specimen collected is the nasopharyngeal aspirate viral culture to demonstrate the virus in the infected cells. If you if you are confused about the diagnosis, you can send specimen to the lab. We do viral culture. Viral culture takes a long time, about 2 weeks. So so you still need to, based on your clinical diagnosis, start treatment straight away before you get the results. the results will only confirm the diagnosis, but management is clinical. So prognosis is in mild cases recover usually 3 to 5 days. Small proportion of cases proceed to bronchiolitis and pneumonia. Next, we go to bronchiolitis. Infants less than 18 months. Inflammation of the bronchioles, so the smaller airways in infants and young children. Bronchioles become inflamed, edematous, and obstructed by mucus. The passage of air to and from the alveoli can be severely restricted and mostly caused by viruses, mostly RSV, 75% in infants, para-influenza virus type 3, influenza A virus, adenovirus, and human metapneumovirus. So mostly 75% RSV, respiratory syncytial virus. Clinical features usually preceded by upper respiratory tract symptoms, rapid and shallow breathing, respiratory wheezing, respiratory distress, hypoxia, and cyanosis. So like I said, asthma, when you hear wheezing, you look at the age of the patient. If less than 1 year old, then you say it's bronchiolitis. More than 1 year, then you probably asthma. But less than 1 year, bronchiolitis. And the sound is wheezing. It's expiratory. Expiratory. The narrowing is intrathoracic in the small bronchioles. So differentiate between what we discussed just now regarding croup with stridor. This one is wheezing. And lab diagnosis, you can diagnose RSV with immunofluorescence and viral culture. So immunofluorescence, you can get the results quite fast, 24 hours. But viral culture also, so after we do IF, we confirm by viral culture. Viral culture takes 2 weeks. PCR takes for about 4 hours, but depends on your hospital whether you provide that service or not. If not, you can outsource to private labs to confirm RSV. But maybe you don't need actually. Based on clinical, you can already start treatment. Prognosis, most cases are mild, but some can become severe with respiratory distress, cyanosis, fatigue, dehydration, and need hospitalization. So infants, you cannot play around. You need to be careful because it can become severe very fast, especially with RSV. Then we go to the lower respiratory tract. Lower respiratory tract is more severe, usually preceded by the upper respiratory tract symptoms with fever, chills, cough, rapid and shallow breathing, muscle aches, fatigue, and chest pain. So 70% of viral pneumonia are due to adenovirus, influenza virus, para-influenza virus, and RSV. Of these, influenza and RSV have the greatest morbidity and mortality, and less common causes are due to CMV, measles, HSV, and varicella zoster virus. So viral pneumonia is much more severe. You can see the lung changes. There is increased respiratory rate, diffuse capitation, and wheezes. So the whole lung is consolidated here. The chest X-ray often shows scattered areas of consolidation and diffuse lesions. Unlike bacterial pneumonia, which produces consolidated areas, is more scattered areas. So each virus, they can produce a spectrum of clinical features, but they have they are more pronounced for the virus. Influenza is more pronounced in the lower respiratory tract. You can see here it causes more severe disease. Can cause pneumonia, lower respiratory tract infection, pneumonia in the lungs, influenza. Whereas for rhinovirus is more upper respiratory tract, colds, runny nose. Okay, this is what we discussed just now. So this table summarizes what we have discussed. Para-influenza more around the tracheal bronchiolitis causing croup. RSV, like influenza, also causes pneumonia, so more severe. So we go to the viruses one by one. Rhinovirus is family Picornaviridae, genus Enterovirus, extremely small, non-enveloped, positive, single-stranded RNA, several hundred serotypes. Optimum temperature for picornavirus growth is 33 degrees Celsius, which is the temperature in your nose. So rhinovirus, it causes common cold. Simple way to remember. The temperature in the nasopharynx, but not in the lower respiratory tract, and there is no vaccine because there are hundreds of serotypes. You cannot target one specific so many viruses which can cause the common cold. Then we go to the coronavirus. Coronavirus family is Coronaviridae, enveloped with linear, non-segmented, single-stranded RNA, 27 to 30 kilobases. It has a spike glycoprotein giving the halo appearance on electron microscopy. So the corona means in Italy is a crown. So this is why it gets the name coronavirus. This is like a crown of thorns, crown. Coronaviride. So the spike, the glycoprotein spike causes the halo appearance on electron microscopy. So this is the cause of COVID-19, MERS-CoV. So it can be classified into four groups: alpha, beta, gamma, and delta. So coronavirus OC43 causes the common cold. Coronavirus from the beta group causes bronchitis. Coronavirus from the gamma and delta causes SARS-CoV, the cause of COVID-19. MERS-CoV is a different one, delta. So for SARS-CoV, the COVID-19, SARS-CoV, there was an outbreak in 2002, 2003 caused by SARS. We just call it SARS at that time. And the COVID-19, the current COVID-19 is caused by SARS-CoV-2. The number two to differentiate between the current one from the previous one. That's why there's a number 2 there. So the virus we call SARS-CoV-2. The disease is COVID-19. I hope you. So if the question asks you what is the etiological agent, you cannot say COVID-19. COVID-19 is not the agent. It's not the virus. The virus is SARS-CoV-2. Okay, severe acute respiratory syndrome, coronavirus 2. And then before SARS-CoV-2, before COVID-19 in 2012, there was an outbreak in the Middle East. We called it MERS-CoV during that time, 2012. We call it Middle East Respiratory Syndrome coronavirus. So the outbreak in 2012 in Saudi Arabia. And so actually it was from the reservoir is bats. The reservoir, if you remember host pathogen interaction, the disease has a reservoir. So actually the reservoir is bats. Why bats? Because the bats, they have a high resting temperature. Human beings, normal healthy human beings, 37. When 38, it's already fever. But bats, they can survive with temperature 45 degrees and be perfectly normal, perfectly healthy. So the virus can live in the bats, perfectly healthy virus in the bats, and the bats are asymptomatic. So they carry the virus without any symptoms. But then when there is an accidental infection to a intermediate host. For example, in SARS, it was civet cats. In MERS, it was the camels in the Middle East. And then for COVID, we suspect pangolin or something in the Wuhan market, wet market. We don't know yet. So many animals in the Wuhan market. So from bats went to pangolin, and pangolin went to something, and then in the end went to humans. So that's the initial cause of the outbreak. And then human cells are infected. We discussed this. The virus infected H2 cells in lung, heart, kidney, and intestine. Same like also in COVID. H2 cells are infected by the virus, lungs, heart, kidney, and intestine. For MERS, it infects the dipeptidyl peptidase 4 and alpha 2 3 sialic acid in the lungs. So transmission is droplets is because it is a very big size, so that's why it's droplet. It's not airborne. We say it's droplet. We ask people to wear masks, social distancing 1 meter, because the mode of transmission is droplet. It's a big molecule. And also through contact. So contact can be direct contact and indirect contact. We discussed this just now. So for the SARS in 2002, 2003, the mortality was only 10%. And the MERS, it was 37%. And for COVID-19, it was also quite high initially, but now has dropped down. In 2022 now, the mortality has reduced a lot because of the herd immunity already. But in 2020, it was very severe. A lot of people died in 2020. So clinical features, you can see the table, the COVID-19, MERS, and SARS. Common symptoms is fever, cough, myalgia, or fatigue, and dyspnea. And less common symptoms like sputum production, headache, hemoptysis, and diarrhea. Then there are also all the other symptoms when it infects the other parts of the body, like the kidney, then you can get renal failure, heart, you can get myocarditis, etc. in the more severe cases. So all patients had pneumonia, acute respiratory distress in 30%, RNA present in the blood 15, acute cardiac injury 12, secondary infection 10, invasive mechanical ventilation 10%, 68% discharge, and 15% mortality. This is in the initial paper in 2020 or published by China. So patients infected with the 2019 and novel coronavirus. Now we change the name. Now, initially, this is the name in 2020. China said it's the name 2019 novel coronavirus. Now it's SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2, the new name. So it causes high amounts of inflammatory cytokines. ICU patients has higher inflammatory cytokines suggestive of cytokine storm compared to non-ICU patients. So when this is why the the SARS-CoV-2 is more severe compared to the previous outbreak, because the current outbreak, the virus can cause this cytokine storm. So the immune system attack itself. The immune system become haywire. There is hyperproduction of antibodies, cytokines, all hyperproduce, and this can cause damage, multi-organ damage. So next we go to adenovirus. Adenovirus is a non-enveloped double-stranded DNA virus. There are more than 50 serotypes with 6 subgenera A to F. So respiratory, usually due to B and C, conjunctivitis B and D, gastroenteritis 40, 41, 52. So it may be asymptomatic, and infected individuals may shed the virus for months or even years, like latent infection, and become reactivated during immunosuppression. Respiratory tract infection can lead to pharyngitis, bronchitis, croup, or pneumonia, and it can develop into severe lower respiratory tract in certain people like infants, children, patients with heart disease, lung disease or immunocompromised patients, leading to high morbidity and mortality. But most of the time, it is asymptomatic. Only in certain individuals, you have to be more careful. So next we go to RSV, respiratory syncytial virus. It is an enveloped, non-segmented negative strand RNA genome with no reassortment, and there are two major groups, A and B. So it has hemagglutinin and neuraminidase receptor binding and group determinant. It also has F protein, which promotes virus cell and cell-cell fusion. And the candidate vaccine target for palivizumab, which prevents monoclonal antibody. So this is the structure of the respiratory syncytial virus. So it can cause bronchiolitis, like fever, cough, dyspnea, and cyanosis in children younger than 1 year old. Can cause fever, rhinitis, and pharyngitis in children, and common cold in older children and adults. So it's more severe in infants less than 1 year old. Virus may subsequently spread to the lower tract, causing croup, bronchitis, bronchiolitis, and pneumonia, and severe lower tract infection in certain people, like infants, children, patients with heart disease, lung disease, or improvements patient, leading to high morbidity and mortality. So next virus is parainfluenza virus. It's caused by paramyxoviridae. There are 4 subtypes, genus 1, 2, 3, and 4. And most infections are subclinical, causes common cold, pharyngitis, and otitis media, and primarily affect young children. 1 and 2 cause croup, 3 causes pneumonia and bronchiolitis. Transmission and pathology is similar to influenza virus, but there are differences. And the parainfluenza virus replicates in the cytoplasm. Influenza virus replicates in the nucleus. It is genetically more stable than influenza with very little mutation. So it's very similar to influenza, but a little bit milder compared to influenza. So next we go to influenza virus. Influenza virus is from the family Orthomyxoviridae. It is an enveloped, negative, single-stranded, and segmented RNA virus. Infection can be asymptomatic, mild, or severe, responsible for more than half of community-acquired viral pneumonia, and major outbreaks occur every 2 to 3 years. Primary manifestation is severe respiratory problems, and there are 3 types of influenza virus exist. Influenza A causes epidemics and pandemics, and they also have an animal reservoir. So like we have a lot of outbreaks for the past years, like H1N1, caused by influenza A. And then there are seasonal influenza. There is also the outbreak, pandemic influenza, and also the zoonosis influenza. Zoonosis like H5N1, the bird flu. You heard about the bird flu outbreak caused by influenza A, H5N1, H7N9. Those are zoonosis influenza. So there are also influenza B, which causes epidemics and not involving animal hosts. So this is less common, and influenza Z do not cause epidemics. So most you hear the epidemics, the outbreaks, pandemics caused by influenza A. So when we say the number is based on these two antigens, hemagglutinin antigen and the neuraminidase antigen. So the hemagglutinin antigen, there is a receptor binding to the sialic acid on the host. So in the respiratory tract of the human, there is sialic acid. So the hemagglutinin of the virus attached to the sialic acid on the human. And that's why it infects the respiratory tract of the human, because the human has this receptor which binds with the virus. So also the role of hemagglutinin is for the membrane fusion and also as a neutralizing antibody target. And for neuraminidase, it removes the sialic acid residues and it causes virion release. So influenza can also be typed by the MP and M1 antigen, and influenza A subtypes is based on the hemagglutinin and also neuraminidase. So there are 16 types of hemagglutinin and 9 types of neuraminidase. So causing all 16 times 9 possible combinations. So this is H1N1 outbreak, H5N7, the bird flu, H7N9 bird flu. So influenza, clinical manifestations, primary, usually acute onset fever, chills, headache, myalgia. It causes non-productive cough and potentially severe even in generally healthy patients. So you know influenza virus is a much more stronger virus because it not only infects people who are prone or are susceptible, but also healthy patients. Also, once you get infected, you get sick. It's much more stronger virus compared to the other viruses. Even healthy people can get sick when they get infected, and it can cause complication not only in those who are young and elderly, but also in adults. But the young elderly, of course, are more susceptible. But healthy adults also can get infected. And viral and secondary bacteria, it can cause complications like viral secondary bacterial pneumonia, encephalitis, and Ray's syndrome. So when you have a influenza infection and then you give aspirin, ibuprofen, then this can cause complications. Some people, they have fever, they don't know, they get uh, this aspirin, then you get complication. So you have to be careful. As a GP, you have to be careful. Don't give aspirin, ibuprofen, non-steroidal anti-inflammatory drugs. Paracetamol is enough. Panadol is enough. Don't give the strong drugs because of the complication. So pathogenesis. Pathogenesis for influenza. The influenza infects epithelial cells, upper respiratory tract and lower respiratory tract. So when you answer question regarding pathogenesis, first you describe how the virus enter the host. This is more like the lecture in host pathogen interaction, you know. So the how the pathogenesis, you recall that lecture. First the virus enters the host and then it infects the cells, and the cells release interferon and to protect both adjacent and distant cell, cause many of the systemic features of flu-like syndrome. So the host produce all the cytokines, interferon, antibodies, and this reaction causes all the clinical features you see like fever. All this is because of the interaction between the host and the pathogen. You get the clinical features. In the end, the antibody response or fight back the infection, so the host after that can recover. Viral damage to the epithelium lowers its resistance to secondary bacterial invaders, so you can get secondary complications, secondary infection. First infection by the virus, but secondary complication is by bacteria. So the virus, you don't need antibiotic, but the bacteria, you need antibiotic. So when there is complication, there is bacteria, so then you need to give the antibiotic. So this secondary is called super infection. The secondary bacterial infection on top of the viral infection. So the bacterial pneumonia can be caused by Streptococcus pneumonia, Haemophilus influenza, and Staphylococcus aureus. So regarding influenza, usually when we discuss influenza, we discuss about the antigenic variation. When we discuss why that occurs, why pandemic occurs, why suddenly we get outbreaks. This is because of the mutations in the virus. So the virus adapts to the human population. Human population antibody increase and decrease, and also the virus mutates to adapt to the host. So there is antigenic drift which occurs with influenza A, B, and C. It's just a small number of mutations slowly occurring. And the reason why it happens because during replication, the virus replication, it uses error-prone viral RNA polymerase enzyme. This polymerase enzyme during replication produces errors. It produces errors about 1 in every 1,000 replication. So most of the mutation is not susceptible, and is not it does not pass down to the progeny. So it's most causes the virus to die, or it does not cause any significant that does not cause any significant. But sometimes the virus can survive and can spread to its progeny. But for drift, it's just point mutations, just minor mutations. So it can cause the yearly change. You need the yearly vaccine changes because of the mutation. But when there is a antigenic shift, when there is a different combination of the hemagglutinin and neuraminidase. Previously, the seasonal influenza is H3N2, and then suddenly there is a new combination come out like H1N1. Then that's why the H1N1 pandemic occur, because there's a mixing between human influenza virus with pig influenza virus mixing, become recombination occur different and produce a new recombination H1N1. So the human host population is not yet exposed prior to 2009. Human host population was not exposed to H1N1. They don't have any antibody, so that's why there's sharp rise in cases, lot of severe cases, global pandemic occur when there is a antigenic shift. But every year, actually, there is a up and downs, and this up and downs is caused by drift. So this is one which causes the seasonal influenza cases. But this one is the pandemic. So this is previous pandemics, the 1918 H1N1, 1957 H2N2, 1968 H3N2, and 97 H1N1, and 2009 H1N1, the swine flu. So although you see H1N1 is different. So since 1968, the whole world was actually seasonal flu was H3N2. But after 2009, the seasonal flu is caused by a combination of H1N1 and also H3N2. So you get vaccine today, the vaccine covers for both H1N1 and H3N2. So for diagnosis, you have antigen detection, and you have molecular techniques, you have viral culture, you have serological assay, and you have hemagglutination assay. So hemagglutination assay is less used currently. More we use all this for. So first we go to antigen detection. Antigen detection is immunofluorescence test of the nasopharyngeal aspirate for respiratory virus. So we use a UV microscope, ultraviolet microscope. So we use from the sample, nasopharyngeal aspirate sample, we stain the virus, and we see using the immunofluorescent ultraviolet microscope to see the virus. If the virus is present, you can see immunofluorescent birefringent green color. If there is no virus, then then it's just black lah. So you have fast result within 12 to 24 hours. You can get results. However, the sensitivity and specificity is less, because It depends very much on your sample, the quality of your sample, how many virus is in the sample, the patient has been infected for how many days already. If early, very early infection, then the virus is a lot, then yes, more you can get results. But if already late after infection, maybe 2 weeks already, then there is no more virus because the antibody has already cleared up the virus. So the very much depends on your quality of your sample. Antigen detection method should be used in conjunction with viral culture. Viral culture will improve the sensitivity, but viral culture takes a long of time, 2 weeks, to see the results. So the gold standard, of course, is viral culture, but takes long time. So this is what we do in the lab. In the lab, we passage the cells. So we maintain cells so that the virus can infect, and then we see the effect the virus causes to these cells. This is called CPE. So this birefringent green is what I said just now regarding the ultraviolet microscope, immunofluorescence staining. So viral culture in the USM lab, we do for RSV, influenza A, B, para-influenza. So all this I said just now. So this is the CPE I said just now also. So after the cells have been infected, it looks like this. So for RSV, you see syncytial formations, multinucleated giant cells. So for RSV, this is for RSV. Cytotoxic effect of HSV, herpes simplex virus, this one. This one is enterovirus 71, there's ballooning of the cells. And this is syncytium formation. Syncytium formation, which occurs due to respiratory syncytial virus, RSV, respiratory syncytial virus. So the virus, they clump together, become one giant cell we call syncytium, multinucleated giant cell. See, multinucleated. So this multinucleated cell we call syncytium. So for treatment and prevention, treatment usually symptomatic, but there is a wheezing, then you need to give bronchodilators, oxygen, and ribavirin is debated. Some are pro for ribavirin, some are against. So depends on the latest studies. The clinician must decide. But you don't need any antibiotic. Antibiotic is for bacteria. So another one agent is palivizumab for RSV. It neutralizes the RSV and prevents severe illness in infants and children who are at high risk. So this is antivirus for RSV, palivizumab. For influenza, there are a few antivirus, amantadine, oseltamivir, rimantadine, zanamivir. Amantadine and rimantadine are chemically related drugs with activity against influenza A but not influenza B. Amantadine was approved for influenza A H2N2 prophylaxis in 1966 and approved for both treatment and prophylaxis in 1976. Rimantadine was approved for treatment and prophylaxis of influenza A in 1993. So this amantadine, rimantadine, this is all drugs. We don't really give anymore. Currently, we give the new drugs like oseltamivir and zanamivir for influenza A virus infection. So during the H1N1 outbreak, we give this one, Tamiflu. We call it Tamiflu. The content is oseltamivir. And okay. And then there are vaccines, influenza vaccines for influenza taken yearly because of the antigenic drift. Antigenic drift So you need to produce new combinations of vaccine. The content of the vaccine needs to be updated every year because of this antigenic drift. So there are trivalent and also quadrivalent. There are kill virus and also live virus. So the contents is monitored by WHO. In Malaysia, in IMR, we send the data to WHO. So, and the WHO will decide what the contents. So, and then they will produce the vaccine every year. And then there are two types, the northern and the southern vaccine. So for the northern hemisphere, they have different vaccine. Southern hemisphere, they have a different vaccine. Because when the northern hemisphere is winter, the southern hemisphere is summer. In Australia, it's summer. In and when the vice versa. So that's why there are also two vaccines. So we give vaccine not to everybody. We give to those who are most susceptible, like people more than 65 years of age, residents of nursing homes and chronic care facilities that house person who have chronic medical conditions, and adult and children who have chronic disorders of the pulmonary or cardiovascular disease. So this is what regarding pandemic. So pandemic, there are 6 stages of pandemic. So there is inter-pandemic stage. There is also stage 2 where there is new virus in animals but no human cases yet. Then there is stage 3 when there is an alert, pandemic alert. Then there is stage 4 and stage 5 where there is new virus causing human cases, but the transmission, in stage 4, there is increased human to human transmission, and stage 5 is significant human to human transmission. So it has to be debated in WHO whether to classify stage 4, stage 5. And then stage 6 is when there is global pandemic, sustained human to human transmission across continents, more than 2 continents, then it's a pandemic. So for control measures, depending on the mode of transmission. So for direct transmission, you need hand washing with soap and water or alcohol-based hand sanitizer. For droplet transmission, you need social distancing, at least 1 meter, and face mask. And for aerosol transmission, healthcare workers they do the procedure in ICU, they need to wear face shield and 95 respirator and full PPE. So for droplet precaution, you can use surgical mask is enough. This would cause one-way protection, captures the particles or droplets from the wearer, typically used to prevent spread of common cold or flu. It is loose-fitting and for general purpose. So for aerosol they need N95 or similar is two-way protection, filters air entering and exiting the wearer, filters at least 95% of airborne particles, sits tightly on the face and mostly used by the healthcare worker during the procedure. So these are my references, the textbook, Javed's, and then for reference, this one is more thick, so you can get only certain parts which interest you from Mendel, and then also the proper virology textbook is Clinical Virology Manual. So thank you. Have you any question? Let's see. It's the chat. Can we have the recording election note later in earning? Yes, sure. Okay, I upload after this. Yeah. So make sure you sign in your attendance. You have to ask I didn't get the QR code for your attendance. You need to ask the course coordinator. The course coordinator didn't give me the QR codes. If you don't have any question, okay, see you again next time. Have a nice day. Good luck. All the best.
Thank you,
Thank you.
Doctor.
Thank you, Doctor.
Thank you,
Thank you,
Doctor.
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 Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.